Welcome to DermPower, where policy meets practice, hosted by the California Dermatology Advocacy Network. In each episode, we examine the legislative and regulatory forces shaping dermatologic care in California and what they mean for physicians and patients. Because protecting patient care means protecting the profession. Today's host is Dr. Ann Haas, CDAN President.
Most of us bill third-party insurance when our patients come and see us. Most patients never see this back office function in our practice, but happens every day. So whether you as a dermatologist bill Medicare or some state or private insurance, there are rules and practices for how you code. One part of billing that has gotten a lot of attention in recent years and in recent weeks, actually, has been Modifier 25. And private health companies have been really willfully, I think, violating established medical billing rules from Modifier 25 to pay the doctor less for every procedure that is performed with a visit. Joining me today to discuss Modifier 25 misery is CDAN Vice President Dr. Alex Miller and CDAN Treasurer Dr. Maggie Parsons. Dr. Miller is a private practice Mohs surgeon and has been on the board of the American Academy of Dermatology, has been president of CalDerm, and is currently the American Academy of Dermatology's advisor to CPT. Maggie has been on the board of trustees of CMA, the California Medical Association, has been active in the County Medical Society, and has been such an advocate that she was recently recognized at an awards ceremony given by the Sacramento Sierra Medical Society for her advocacy efforts on our behalf. So, Alex and Maggie, welcome to DermPower. We are the podcast of the California Dermatology Advocacy Network. So we're going to start with you, Alex. You are the coding guru. What's Modifier 25?
Well, thank you very much, Ann, and a pleasure to be here, and thank you for the magnanimous introduction. So Modifier 25 is simply there to use when we specify a separately identifiable, unique evaluation and management, which basically means office visit, that is separate from what is included in a minor surgical procedure. Meaning that if we do a minor surgical procedure, which is defined by a procedure that has a 0-day or 10-day global follow-up period, and we also do a separately identifiable E&M, that is office visit service, for a defined purpose, then we can bill for that. But we have to distinguish that is a service not included in what's included in the procedure valuation and the procedure descriptor. So then we attach Modifier 25. Now you may wonder, well, why is that important? Well, you probably want to get paid. That's why it's important. Because if you don't put that Modifier 25 on and you did a reasonable, necessary, separate E&M on the same day as a minor surgical procedure, you won't get paid. So, first thing to know is, well, what's a minor surgical procedure? Because not always everybody may know. A 0-day global period procedures are minor procedures that are biopsies. That is, a shave biopsy, a punch biopsy, an incisional biopsy is a 0-day global. Mohs surgery without any reconstruction, that is, Mohs surgery alone, is a 0-day global procedure. 10-day global procedures for dermatologists are destructions, that is, destroying actinic keratoses, inflamed seborrheic keratoses, or malignant lesion destruction, that is ED&C as it's commonly called, and also simple excisions and simple repairs that are either simple or intermediate or complex, not simple repairs, but just repairs that are simple, intermediate, or complex. So that's the basic description of those. Why is modifier 25 so important beyond its definition? Well, it's because dermatologists use it a lot. As a matter of fact, the Office of Inspector General in November of 2025 released a document called Dermatology Providers Generally Met Medicare Requirements for Evaluation and Management Services Performed on same day as minor surgical procedures. Well, what's the big deal? It's because in their survey of 100 practices, they found that about 90% of claims were appropriate and appropriately documented for modifier 25 use, but 10% will not. Well, you'd say, well, that's only 10%. But when you consider that dermatologist claims, 61.5% of them submitted had modifier 25 attached to them. It's expanded to the general Medicare claims population. That was $62 million, that 10% that were not adequately documented to support modifier 25, $62 million in, quote, improper payments, unquote. That means that your contractor may be looking at your claims at some point. And it certainly means that private insurers are too. So consequently, it's very important to appropriately document that a separate service was done. Now, what's included in a minor procedure? Well, it's the preoperative, the intra-service, and post-operative. The preoperative is evaluating the lesion, talking about the lesion, setting a diagnosis to the lesion. If you're doing a biopsy, for example, on the same day, discussing with the patients the biopsy itself, risks, benefits, etc., and then postoperative care as well, and postoperative instructions as to what to do following that. That's quite a bit. You have to justify what is separately billable from a procedure. And that is, you consider what's in a procedure, say a biopsy, and did I do anything separate from that? And when you separate it off, then you decide, do I have a separate E&M? And what is the level of the E&M? And then, if it's justified, you attach a modifier 25, or will be on the horizon, rapidly approaching, and the thing that's approaching is your insurance companies saying, we don't want to pay.
That always seems to be the problem. Let's get into the weeds with an example, and maybe you can pull it apart for us. So I see a pediatric patient who has a wart, and I freeze it with liquid nitrogen, and that's all I do. I could only bill for the procedure because that's all I did. I didn't look at anything else, right?
Correct.
Okay. The evaluation and management component is already built into the procedure fee, right?
Correct.
Okay. So let's say this child has a rash, which I also evaluated, and then I froze the wart. Okay. We're not paid to evaluate the wart and treat it again. So actually, the insurance plans are sort of getting a bargain, right? Because the kid has a rash, so I would be billing for the evaluation and management service of that separately. Okay. So health plans are already getting the evaluation of the wart for free. Is that right?
That is included in the procedure, correct.
To designate that the wart was a separate treatment from the rash, that is when I would put my E&M code in for the rash and apply my modifier 25.
That's what you do. And then most importantly is you also document what it is that justifies the modifier 25, that is the evaluation and management.
So how exactly are the health plans supposed to reimburse dermatologists under modifier 25? How does this all work?
Ideally, and the way they should reimburse is in full. That is, they should reimburse contractually via contractual obligation fee schedule for the destruction of the wart, that is the freezing. and they should reimburse in full for the E&M, that is the evaluation of in management code selected for the diagnosis and plan and or treatment of the rash. There should not be a discount for either one of those entities being billed.
Okay, so we're doing it right, but that may not make any difference. Maggie, we're going to switch to you because all of a sudden we have had a new recurrence of modifier 25 misery, which really is very reminiscent of what we have gone through in California for the last 10 plus years and certainly could see again in California. Take us back several years. What happened?
In 2017, Anthem Blue Cross put forward a proposal to modify how we would be reimbursed when we use Modifier 25. They wanted to take the part of the rash and the wart, they wanted to make it so we would only get paid 50% for the evaluation management of the rash if we were doing a 25 and adding the wart treatment onto the same visit. And so that was basically taking all of our thoughtful work, our management, our evaluation, our explaining to the patient about their rash and their disease, whatever prescriptions we might have written, all of those would then be devalued by 50%. We could treat a complex medical condition and not be paid if we also did the wart that same day. And that really is unfair. We're doing the work of both. CPT guidelines are very clear. We should be paid for the work that we do and when we're thoughtful and take care of multiple things at a patient's visit.
In this scenario, I'm a smart dermatologist, right? I would say to my kid's mom, you know what? Let's just deal with this rash today and we'll bring little Johnny back in a week and then we'll treat the wart. But that was not going to wash, right?
The payer also suggested that if we were to have patients back later for procedures, that they would find us as being after the money and inappropriate. So there was a concern there as well. That's multiple visits, that's decreased access. We only have so many people we can see a day. And it really takes away from what we as dermatologists are able to do efficiently in an office-based practice and take care of people in a way that they're not making multiple visits, missing school, driving their parents that are older to an appointment, all of those things.
This has just been resolved within literally the last 2 days in Michigan. They have been fighting this fight for months and actually reached out to us to ask what we did and what our experience has been. And in trying to help them, I reviewed some of the arguments and the literature that they used. But what was really striking for me was what the Blue Shield book actually said about what would happen to physicians. The Blue Cross Insurance Manual in Michigan said the physician may not refuse to provide covered services to members based upon Blue Cross's payment level, benefit, or reimbursement policies. And providers may not discriminate against members on the basis of other, disabilities and whatnot. And they went on to say that healthcare providers must provide covered services to Blue Cross members in the same manner and the same quality and promptness with which they provide services to patients with other health plans, and that providers may not intentionally segregate members in any way or treat members in a manner or location different from other patients receiving healthcare services. So essentially, they're saying, and what the Michigan dermatologists have told us, is they faced potential de-enrollment from the insurance plan if they try to do anything other than do the procedure on the same day as the visit, even though they were going to risk having the visit reimbursement cut by 50%. I mean, is that legal? Alex, how does that work from the CPT perspective?
Well, from a CPT perspective, I must say that CPT is not a billing type of group, but rather it defines codes and defines coding conventions. And certainly the coding convention and the expectation is we get paid in full for both services, both the minor procedure and the evaluation and management identified with a 25 modifier.
Okay, so there we have it from the guru. So Maggie, when all this came down in California in 2016, 2017, What happened? What was involved in trying to deal with this?
In working with any issue that comes at us as dermatologists and our ability to care for patients, be paid appropriately for the work we do, not have inappropriate, unreasonable cuts to reimbursement that helps us keep our offices open, it's building a coalition, bringing people together. The Blue Cross issue came right before the California Medical Association House of Delegates, Dr. Haas and myself, me in the boardroom, her in the specialty section delegation, grabbing the president of the CMA at that time, an ENT. ENT and Ophtho are some of our best allies in this. They also do a lot of in-office procedures, and building that coalition and fast tracking CMA leadership, CMA's lobbying power to work also with the AMA and the AMA's work. And at that time, our colleague Jack Resnick also happened to be chair-elect of the AMA Board of Trustees. Having that coalition, having our specialty with places in leadership, and trusting our colleagues and working together, we were able to really advocate for our patients, because when we advocate for our patients and it's clear they'll have delayed diagnosis of cancer. I'm sorry, it's so great to see you and treat your psoriasis day. That funny mole over there, they're not going to pay me to biopsy it today. Your insurance, I'm going to have to do that some other time. But yet at the same time, the Michigan people were being then threatened to not be able to do that. But we need to be able to care for what's in front of us, to not delay care, to not delay access. If we were to do something with multiple appointments rather than our efficient way of seeing people, or something that is diagnostic to something complicated in ENT and ophtho, that's delaying care. That's delaying diagnosis. That's requiring someone to take more time off work, a kid out of school, someone taking time off work to be their parent that is less mobile, or a family member that is less mobile to an appointment. That is just not good care of patients. So the effort really is to come together, get the House of Medicine together, and advocate for the patients. And even ask on the Zoom calls we did, we'd ask the payer representative, Mr. Blue Cross, Mrs. Blue Cross, do you want to have to make 3 visits to get this taken care of? Do you want to have to go off work to pick your kid up at school 3 times? Those types of questions really put it in the place of what are we doing? How do we care for people? What is the best healthcare?
You were on a couple of those Zoom calls with Mr. and or Mrs. Blue Cross. Who else was on that call? Which sister societies and coalition member did you actually have on that call?
I've actually been involved with this in both the Blue Cross, a Health Net, a Cigna, and Blue Shield recently. The team involves CMA. We're fortunate in California, we have a very strong economic services with Jody Black and her team here in Sacramento. The AMA and their team, the CPT people, getting on a few of the calls in the last couple years. Representatives from ENT, Ophtho, as well as our American Academy of Dermatology, the otolaryngology, and the ophthalmology academies, also sending in letters of support, getting the House of Medicine to all contribute and support. Our family practice colleagues, ortho, they all do a lot of injections and other procedures in the office as well, getting all of the specialties involved in the House of Medicine to get those letters in, to speak up and be part of this and have a strong position on behalf of the patients.
You all beat it back, right? We won that.
We won that. 2017, the first big Modifier 25, it was a win. We got it initially. They were going to just go from 50%. After the AMA meeting in December, they were going to only reduce 25% with a pending March 1st deadline, February 23rd of 2018. We got that letter that they were not going to implement any policy. They'd been stacked high with voices of everyone that could, saying this is not good care. And so we won totally, not any reduction initially, but down to no, we're not doing that. We see what you're saying. You're right. We need to take care of people, and recognizing that we are efficient in what we can do in an office.
That was fabulous. But you would think that after one failed attempt at breaking the coding rules, that the health plans would have learned their lesson. But what happened in the subsequent years up to and including 2024?
In 2018, it was Health Net and members of that same group of people. In 2022, Cigna was going to do it. Then we beat that back. And then again, in 2023, Cigna sent it out again. So we beat down Cigna twice for the inappropriate Modifier 25 usage. And then most recently, in 24, it was Blue Shield. They were going to stop anything with a Modifier 25 was going to have to be appealed. every single modifier 25. And we all know in dermatology, we know it's over half our visits. The OIG report putting it at 62%. Do you imagine the delays in trying to process to get the cost of doing appeals? And a lot of appeals are electronic, but they're often denied electronically. Then you end up having to do a paper appeal. It's just so burdensome and costly to all of those of us that provide care. The idea of having to appeal more than half, 60% of my care is just insane in the idea of running a practice. But we got the team together.
Yeah, absolutely. California's been successful in pushing back against the Goliath of healthcare industry, but this is going on nationally. They tried it in North Carolina. They've been trying it in Michigan. We heard just literally within the last 48 hours that that problem appears to have been resolved in Michigan. But that doesn't clearly, the history in California suggests that this is not the last that we in California have heard of this. In other words, they may come back and try it again.
It's really difficult. The OIG report, when you look at that, it's a small number, but barely 10% had errors in their claims. And that means that most dermatologists and other specialties also, we do things correctly and honestly. And we're doing the care, we're providing the care. We need to be recognized for doing what's right. One of the other arguments and discussions with some of the payers is recognizing that all of these societies continue to educate. Alex has been on, I don't know how many American Academy of Dermatology seminars, articles, podcasts, web-based things, continuing to educate our members to do our best work every day, not only in caring for patients, but conscientious billing. And I think when we see that we really are doing our best every day, the majority are doing it correctly. We need to keep not seeing this come at all of us with these payers trying to ding us for doing good work.
It was only 10% of the modifier 25 claims were not supported. Can you imagine trying to appeal all of the ones we're doing right? It would be a nightmare.
And a nightmare for the payer. We also, in talking to payers, reminded them that we know that we mostly do it correctly, and we continue to educate to get that number even smaller on those that are having errors. The cost to the payer is real. If they're going to have the staff to continue to review all of those appeals, that's a cost to them as well, and to recognize it's doing them no good either.
Among the arguments that were given, Alex, to Mr. or Mrs. Blue Cross, from the CPT perspective, what would the AMA CPT person have likely told them about how these codes are constructed and why what Mr. or Mrs. Blue Cross was trying to do was not valid?
Well, it's pretty obvious. And that
Not
is,
to them.
well, not to them because they want to pay less, obviously. But to us, it's pretty obvious, and that's simply based upon fact. And the fact is that the procedure codes, the minor procedure codes, 0 and 10-day globals, have RUC, that is RVS Update Committee vignettes. And those are documents that specify what is included in that procedure. That is, what pre-service work is included, what intra-service, that is the procedure itself, and post-service, that meaning what is done after the procedure is concluded. And we clearly demonstrated that none of that work relating to the minor procedure was included in the E&M that is separate. That is, there was no practice expense, no anything that was included in the separate E&M. No cognitive work by the physician was included. Basically, the only thing included was the patients in the room. Well, that is not adequate reason for a payment reduction. And I think stressing that particular feature imprinted on them that they are truly countering or doing things counter to CPT rules, convention, and what is described in minor procedures. There was no overlap, as the insurance companies said. That is, no overlap of work from the procedure to the totally separate physician work for doing a separate evaluation and management.
Yeah, and that's a great argument. I know neither of you are lawyers. Do you think anything, this maneuver by the insurance companies with respect to Modifier 25, is it even legal? Or do
It,
we, as dermatologists, just sign our life away because we signed the contract saying that we're going to be a Blue Cross provider and we get what we get?
The difficult thing is the AMA CPT codes is a set of all this work that people such as yourselves have done, putting together this huge compendium, and it is then used in agreement by all of for Medicare and the payers, and that is how it is. It's within different states, there might be some rules around CPT legality, but it's not exactly a legal rule. It's a trust of how things are used to be used fairly. It gives us a process and a system to have something to base it on. And having it all be the same system is really, I think, the only way this can all work. And so when you ask about legality, it gets a little complicated and it may get down to state by state. But it really is a trust in a system that has put decades of work evaluating, reevaluating, and putting value in. And CPT and RUC and RVUs are reviewed regularly as medicine changes, as new technologies come in, things are reconsidered, reevaluated. Many of us have done surveys on what we use and the supplies and the time to take things. So it's a trust between all of us, but the legality gets a little tricky. And that is one of the frustrating things about it, in that it is and it isn't. So
Kudos to you for bailing California out yet again. Unfortunately, it's sort of like whack-a-mole. This may not be the last for California, since there are so many physicians here. It's a big state. Kudos to Michigan. I know they were really very, very apprehensive. Their deadline was coming up and they had not heard anything from their Blue Cross provider. And I think they're probably celebrating a lot in Michigan right now. But I think for us and for the rest of the country, this is something that we need to keep an eye on because I think modifier 25 misery may be an ongoing problem for states that have thought that they had solved the problem, and like California, we'll find a few years later that the problem just keeps coming back. Any last thoughts about what dermatologists can do besides be aware of this? Certainly participating in the sister societies that can help coalition build with us in solving these problems is useful. Any last minute thoughts with respect to modifier 25 misery?
I think one of the crucial points to consider with respect to appropriate utilization of modifier 25 is defining what is really a separately identifiable and necessary, and again, necessary, because Medicare, for example, pays for care that is reasonable and necessary, and it's for the improvement of structure and function of the body. Consequently, if one is doing a procedure and in the process, oh, look at these, you have some seborrheic keratoses, and the patient didn't complain at all, didn't care at all, you're just running across them. And then if you decide, oh, I'm going to list those, and now I have an E&M, I have at least a 99212 or level 2 type of diagnosis there. That does not really meet the criterion for reasonable and necessary. Patient didn't complain. They're completely innocuous growths. You just happen to see them, and now you're adding them on to this diagnosis list. That, upon review, will be rejected as not reasonable and necessary type of E&M. So be careful what you call an E&M that is separately identifiable. It also has to be something that requires a note that the patient said something or the patient may have been concerned. Now, obviously, if you run across what looks like a melanoma and the patient has no concept, that's a different situation. But if it's just a plain, quote, nothing, unquote, and the patient had no interest whatsoever, you may have a difficult time supporting a separate E&M on that one.
So you're saying understand the coding and code it correctly.
Exactly.
Maggie, last thoughts.
Thank you, Anne, for a thoughtful discussion with both you and Alex today. I think one thing is to always pay attention. Read your notices. Often these come to head because of that something that was slipped in a billing packet, or came across an email that may have gone to the billers and not necessarily to you. So have a relationship where you know that your billers know to pay attention when they see something coming. Don't presume that, oh, they already know about this at whatever, or AAD or CMA or AMA. Just pay attention, reach out to your organization and say, hey, have you heard about this? And, make sure that we're getting it on our radar to advocate and protect physicians and patients. As Alex said, I'm big on educate yourself, educate your colleagues, the other people in your office. Also know your colleagues. Our partners have been ENT and Opto very often through this. So education of your staff, your colleagues, and know how important it is that we work together with our specialist societies, our state societies, our AMA, and working together to be as strong as we can be. Bigger we are better. And be engaged in those organizations. And if you don't have the time, support the organizations. We are working every day in our medical societies to support physicians to be able to practice in our best, most ethical way that we can take care of patients. So be engaged and support, and keep those ears sharp and listening, and the eyes focused on mail that comes through. Pay attention and support.
Great advice. And, it really was the successful collaboration between all of those different societies, the California Medical Association, the AMA, our sister societies, the AAD, the ASDS,
Yes.
and then the other specialty collaborative societies that really helped us push back and gain success against this Modifier 25 misery that we have seen coming back at us. And not only supporting them, but joining them, I think, is huge. Thank you both very much for all of your work on this and many, many other issues to keep us practicing to the highest level of dermatology that we can here in California. Really appreciate it. And we will be inviting you back on future podcasts to pick your brain and have you share your wisdom. Thank you for joining us today.
Thank you.
Thank you.
DermPower is a production of the California Dermatology Advocacy Network. CDAN is a registered 501c6 organization representing the hardworking board-certified dermatologists in California. Thank you all for your amazing work. Please make sure to follow CDAN on all our social media, Instagram, Facebook, YouTube, and LinkedIn, so that you never miss an episode of DermPower. If today's episode sharpened your understanding of how policy impacts practice, then we invite you to join CDAN, especially if you are a board-certified or retired dermatologist. Learn more about our work at www.cadermadvocacy.org. Advocacy isn't optional, and CDAN is dedicated to protecting our patients in dermatologist-led care in California. See you next time.